So this is Dr. Kathryn reporting for Room Now at the ACR 2019 meeting in Atlanta, Georgia. So I just gotten out the session that reviewed the draft guidelines for arteritis. And so the three types of arteritis, vasculitis that were reviewed included GCA, included Takayasu's arteritis, as well as polyarteritis nodosum. And so some of these guidelines, actually opened up doors to more questions that weren't necessarily answered by the guidelines committee, but I'm just going to give you the highlights of what I learned and what they recommend. For the first thing, all right, if you're going to diagnose GCA in a patient that you have high clinical symptoms, get a temporal artery biopsy, bypass the temporal artery ultrasound. Okay, so if you have a choice, do that. If you have a choice, do just a unilateral biopsy, and if that's negative, your suspicion's high, then go for the bilateral. And then when you tell the surgeon to biopsy, you need at least 1 centimeter of temporal artery length, okay? Anything below that, you're probably, because it's skipped lesions, may not be able to make a diagnosis. And not only that, they do recommend, now this is the part that's important, a baseline, non-invasive, extracranial evaluation of the large vessels. So now this is where the guidelines committee didn't specify of what, right? So they were saying of the aorta, but do you use an echo? Do you use abdominal ultrasound, CT angio, what? All right, that wasn't clear at all. Okay, so how do you go ahead and treat, right? So the recommendation is immediately start them on high-dose steroids. So high-dose steroids meaning a meg per keg per day of prednisone up to 80 milligrams a day with tocilizumab, all right? And it doesn't say, do they favor Q-week tocilizumab versus Q2 weeks tocilizumab or IV tocilizumab. So, and then for cranial ischemic temporal arteritis, then you really need to pulse them with IV glucocorticoids. That we all know. For extracranial complications, you can consider adding methotrexate if they're still having disease in patients with tocilizumab and also on glucocorticoids. And then this is the part that a lot of us found confusing because in the audience evaluation and questions, there were so many questions about this, but they never answered it. So it says here that if surgery is required, all right, if surgery is required, you need to perioperatively give them high-dose steroids. So complications from GCA, surgery required for vascular complications, give them high-dose glucocorticoids. So why? We don't have the data presented on that. And then for patients who relapse, when off of all therapy, you can go ahead and use methotrexate with tocilizumab who have cranial symptoms without having to go back on glucocorticoids. Optimal duration of glucocorticoids, optimal duration of these non-glucocorticoid therapies have not been established and has not been recommended. And if patients have already been in remission for a while, consider long-term monitoring. So that's every 3 to 12 months, right? All right, so let's talk about the other arteritis and vasculitis. So with regards to the other ones, let's look at Takayasu's. So with Takayasu's arteritis, what they do recommend is using non-invasive imaging over catheterized imaging. They also recommend high-dose glucocorticoids, just like in GCA, but they say do not use tocilizumab. If you're going to do anything, use a TNF inhibitor or a non-biologic DMARD as methotrexate, azathioprine, leflutamide, or myclophenolate. Data, none. None was presented. Dose, not presented. Duration, not presented. Not sure. All right. Monitor the disease every 3 to 12 months if they're in remission, and get imaging study every 6 to 12 months. And labs must include inflammatory markers. Which one? Didn't say. All right. Imaging options that was presented is on my Twitter feed. So you can go to @KDow2011. All right, keep going here. Sorry. Patients in remissions, 6 to 12 months, you need to go ahead and taper off the steroids. The goal is 0 steroids. For asymptomatic imaging progression, observe, don't do anything. For worsening limb ischemia, increase immunosuppression rather than send them to surgery, okay? For asymptomatic inflammation in a new vascular territory. So these patients have new involvement, but they're asymptomatic. What do? All right, if it's rapidly progressing, if it's a new area, go ahead and increase your immunosuppression. And again, this is where I don't understand where the data is coming from, but they recommend peri-procedural high-dose steroids if patients have to undergo surgery for a vascular complication. So, you know, that stenosis or that ischemic cranial involvement, if they're going to go undergo surgery, really bump up their steroids. All right, so let me go ahead and talk about polyarteritis nodosa, all right? So these are the drafted guidelines recommendations. If you have skin involvement, do not get just a superficial, simple skin punch biopsy. You need to do a deep skin biopsy. You want to go ahead and see if you can get the nerves. And now he also mentioned you can do a punch within a punch, so you do an initial punch biopsy, then you go even deeper. And now that actually has pretty good yield, is what he says. Let's say a patient has foot drop. All right, you have the choice of getting a nerve biopsy or a nerve and muscle biopsy. Get both nerve and muscle biopsy. And then for patients with abdominal symptoms, use abdominal vascular imaging for diagnosis and also to gauge the extent of disease. Because people who have vascular involvement or visceral involvement basically have an increased mortality over 5 years. For active severe disease, this is where it's important here. You give IV pulse steroids and cyclophosphamide, oral cyclophosphamide 2 mg per kg per day, all right? They didn't say, and that's a recommendation over rituximab or any other biologic or non-biologic DMARD like Rituxan. Now, for patients who have rapidly progressive disease, renal disease, they really don't recommend plasmapheresis or plasma exchange, okay? Now, the goal is to be off of all steroids by 6 months. Also, in patients who decline cyclophosphamide, you could go ahead and use one of the other steroid-sparing agents, such as methotrexate, but they really didn't go into a lot of detail what some of these other or steroid-sparing agents are or the dose. If the patient's in remission after 18 months, stop all your medications. Usually this could be a self-limiting disease. Now let's say a patient presents with foot drop or some neurologic manifestations, do serial clinical neurologic exam. Don't go for serial EMG nerve conduction study because your patients probably won't come back, right? And then physical therapy is recommended for patients with weakness and deconditioning. And then for non-severe disease, they did say that you don't have to necessarily go immediately to cyclophosphamide, but a non-glucocorticoid, non-biologic medication. And then in patients who've had abdominal involvement, go ahead and do follow-up serial non-invasive imaging. And now there's one more thing that they added to this guideline that I thought was really cool. All right, patients who have the ADA2 gene mutation. So these patients are DATA2 deficient, right? And if you have that in a PAN patients, these patients are at high risk for stroke. And so you really want patients who present with stroke, high suspicion of PAN, check them for DATA2 deficiency. Okay, so I had posted all these in my Twitter feed, so I hope you'll check them out. Also, for more information, go to roomnow.com, Dr. Kathryn Dow.